So without further ado, we're going to start off with our first session. And our first session is somebody we're all familiar with, so I don't want to give a long introduction, but he's very much a sort of firm friend now of Sanibel and myself particularly. I look at him as very much a mentor of someone that I aspire to be like, so it's always a pleasure to have Rob here. And he's going to look at some of the insights that he's gained over the years, looking at his international collaborative Perfusion registry. So Professor Rob Baker, please.
Thanks, Richard. Gee, how exciting was that to have Francesca's presentation? It's really fantastic to see more and more people, more young people getting involved in developing the way our profession and our specialty looks after its patients. So it's really very exciting. So over the next 25 minutes or so, we're going to explore some of the current thoughts around the Australian New Zealand registry, a little bit of some of the data that we've looked at, and hopefully you guys will find it a little bit informative. So first of all, I just wanted to start off with our vision statement. This is what we believe that we're about in our registry. We want to empower the entire cardiac surgery team members to improve the understanding and practice of cardiopulmonary bypass, to improve the cardiac surgical patient outcomes. And it's about not just being in the perfusion space, but being over that entire cardiac surgery journey. And it's about always remembering that we're serving our patients every day of the week. When we're at a conference like this, we're here to serve our patients, to go home and take better ideas home and make sure we do a better job. So what is a perfusion registry? Well, we like to consider ourselves that we've got what we call a quality registry, where the focus is very much on looking at the data for a variety of different reasons. In essence, it's just a large database that collects all kinds of information. We're all familiar with the schematic of that quality improvement type cycle. In our situation, sites submit their data, they get feedback from their data, and we use it for a variety of reasons. But it's really connecting the patients, connecting the hospitals, and connecting us as clinicians, and interlocking all of those different areas to make what we do more reasonable and better for our patients. As I said, our sites submit to a de-identified, centralised repository. But we're thinking this model's worked for us for nearly 20 years, but it's historic, it's outdated, and we're looking at working out how we can move forward as a registry to the current technology. I mean, we're always going to be behind in a technological sense, but we want to move forward into a cloud-based system, and we're well down the pathway of building those relationships to allow us to do that. But, you know, you look at a registry and you think, you know, are we really starting to do the right thing? Are we, you know, benchmarking appropriately? Are we giving the people that participate in our registry, that is, are we giving the perfusionists and the cardiac teams enough insight into the data, enough access to the data? And historically, that's been a real limitation for us. We know that we've been successful in generating some new knowledge. We've got some nice publications, but how effective are we at the clinical interface? So historically, our registry has fed back annually. And like, you know, a lot of registry feedback, we have these very nice reports, and our reports are incredibly extensive, but they're way outdated by the time the clinical team actually receives them. So we've been working on how we can make that a much more accessible, and also something, I guess, we want to make it tailorable to you as an individual, in our case, you know, our contributors, such that they can look at what time period they might want. Or as Francesca mentioned, you know, you might have a core data set and non-core data set. You know, non-core cases tend to be fairly ignored in registry data. And I think it's important that we can access that information. So what we've done is we've been working towards developing a dashboard for our registry. And at this part of my presentation, the plan was to flick over to a live Power BI demonstration. But unfortunately, one of the vagrancies of travelling is that sometimes your telephone doesn't exactly work properly. And that shouldn't be a problem, except for the whole world now has two-factor authentication. And all of my two-factor authentication comes via text messages. And I've spent probably the last day and a half trying to change that, and you need two-factor authentication to change it. Anyway, it doesn't matter. I did bring a backup plan. So this is what our registry dashboard, if you will, starts to look like. I think what I'll show you is there's lots of information there, and then you as an individual could drill down pretty well wherever you like, or you could ask for things to be changed. It's all very simple. But you can see over here on the right-hand corner, you've got hospital, so you can look at all the data, or you can look at your hospital. Race, case type, core or non-core. So if we want to look at the core data set, and in our situation, we call core cases graphs, valves, and valve graphs, and then everything else comes in under non-core. We can look at sex, if we want to look at the data in terms of males and females, different body sizes. Whatever anyone asks for, our plan is to be able to make it accessible, and it's fairly easy to do in this dashboard framework. So between slides, you can see I've gone from 14,000 cases, 2019 to 2023, down to a smaller time period, and I'm looking at core cases. So you can flip around and you can just see differences as at will as you go along. Okay, we've gone now from core, all sex, to core female cases. What the idea is to let you see what you want to see, and hopefully that'll become evident as we keep going forward. One of the other things we've heard talked about is measuring or reporting how well we perform. And historically, we've had a number of quality indicators as part of our collaboration. It's an infinite line of what we can look at and report. And the concept of taking the guidelines, the new European guidelines, and having a quality indicator or a panel that reflects all of those is fantastic, and something that is not overly hard for us to build in, as we've probably got all the metrics that we require to report. So here you can see 5 different quality indicators for all cases. Then I've just got to, okay. So now you say, okay, not really interested in looking at all the cases, let's just look at one patient type, so one surgical type. So here we've got coronary artery bypass grafting, and I can click on any of those colours and it'll pull up the results or the outcomes for those groups of patients. So it gives me access to see what's going on. And you'll see the quality indicator bars have a frame around them and then a central core. So that allows us to compare back to the original information that we're seeing. So here was the all comers, and then if we look at the core, we can see the differences. Yeah. So there you can see that people are actually performing very similar on core and non-core cases. Then we can look at different quality indicators this is for males. Here we're looking at some goal-directed perfusion parameters, and for George's benefit, we don't have DOT VCO2. That's not available throughout our group. Then we can look at transfusion. I mean, how many of us actually want to see what our transfusion practice actually looks like and be able to, drill down on different patient groups, different procedures to know what's going on. And here we can see transfusion in females. So here's our whole practice transfusion, and then you can see the dramatic increased transfusion rates in women. So we're driving people to think about what they're doing, what their practices are, what they can do to reduce, in this case, say, the exposure of women to red blood cells or any transfusion products. Okay, where it gets really enjoyable is that was our looking at a hospital level. But what do we as individual perfusionists do? So we've introduced into the dashboard the ability to look at individual perfusion practice, but not just within your hospital, over the collaboration. So if you're a unit, you could drill it down and look at your hospital, or you can compare yourself to the whole group. And I think that just gives us the opportunity to continually improve our practices. And you can see here on this process measure of a DO2 above 270, and we know the number doesn't matter. It's about what the consistency in practice is. And we can see here, we've got huge variation between the different sites contributing and the different perfusionists practicing in our region. This is the DO2 for our female patients. I mean, look at the drop in that. I wouldn't have predicted that prior to seeing this at the, at this sort of granular level. It was a real sort of shock to me that there was quite this difference. So that's an area that we're going to really drive and work on. Now, looking at outcomes, as a perfusion team, we often don't focus clinically enough on outcomes. And as we heard from Francesca, developing a model that looks at the patient preoperatively, takes into account their intraoperative journey, and then you see the outcome is really important. Here, this is sharing AKI class 1 or above. I actually take a different slant on this. I think it's really important to report all AKI injury. And I think that the morbidity associated with class 1 kidney injury is really significant and something we really need to examine. But here you can see that the rate of kidney injury by perfusionist varies. Now, if you think about that, the reality is that pretty well we're all given the same cases to pump. So why is there this enormous variation in outcome? It's something we just need to work on. You can see there's variation between hospitals, and you can see there's variation between perfusionists. And then if we again, sorry, this is looking in females. What have I got there? And this is looking at all comers. You can see that, whoops, where we go? There we go. Our female patients have more kidney injury as well. Okay, now looking at putting both of DO2 and AKI on the same page, so you can have a look there and see, this is about sharing the data and allowing us to look at what we're doing. And you can see there, if you look at the yellow bars in the bottom DO2 compliance panel, and then you look at the rate of AKI, it's higher in those with poorer DO2. We're not talking about causality. We know there are lots and lots of different things happening. However, if I was looking at this and this was my hospital, I'd be saying, well, why is there so much variation? What are we doing differently? How can we reduce and become more comparable to other groups? It's about exposing us to what we do. It's all very good for us to go and we pump our cases and we think we're doing everything right, but we need to be shown and share our data continually. So this is looking in the female group, same sort of scenario. Okay, so this is our ANZ CPR registry. We've got access to all this wonderful information. But imagine, what about if we were able to easily collect or connect, I should say, with other registries. In Australia, we have the ANZ data registry, which is a renal replacement and transplant registry, our national death index, a registry that I imagine should exist about quality in life and follow up. Imagine how much more power we'd have if that linkage occurred and was available to us. But then, part of the theme of this meeting is a bit of, what does a global picture look like? So I started off thinking, well, maybe if we can get more sites in Australia, that's part of our plan, our mission to grow our registry. But what about if we can get sites from all over the world contributing to a central data repository? And this is something that is being talked about. It is something that people are really keen to see established. I'll just diverge for half a moment. You'll see there's a number of silos in some of these pictures. And historically, we've sort of talked about medicine as perfusionists are in one silo, anaesthesias in another silo. I'm sort of using it more in the sense that our hospitals and our institutions are silos, and that we need to break those barriers down and become more interconnected. And if you come to Australia, there's a great silo tour. It's a driving tour, and you drive all around the country and you can see these beautiful artworks that have been, I guess they started about 20, 25 years ago. And they're just stunning as you drive into a little country town that's got one shop, one pub and one church and a silo, and it's just beautiful. Okay, so thinking globally, there's a whole lot of considerations that we have to think about. We have to work together. We have to think about what do we actually want. And, you know, from my consideration, there's a big opportunity at the research level, but the gift is at the individual level, at the sharing of the data, at being accessible. That's what we've got to make sure we keep going forward. We've got to make it that people can see what they actually want to see, and that people can get access to the data. I'll just circle back on that. Our, I guess, within our vision and mission is that anyone can ask to use ANZ CPR data. We worked out a long time ago that we didn't have the resources, but we had the data, so it's available. Looking at that global, what it might look like, there's obviously infrastructure questions, there's how we integrate devices, there's all these magic, what's the word, infrastructure terms, developing APIs, all this sort of stuff. But it's all easy because there are people who are specialists in this. As perfusionists, we don't have to do this. We have to collaborate with people who can do it. But I think, obviously there's things like data security. Again, that'll take care of itself because we won't be able to do this if we don't use the rules. But this area of interoperability, to me, is the seminal piece. And this is a quote from the Australian Digital Health Agency, but at its simplest, interoperability is the ability to move information easily between people, organisations and systems. So it's between perfusionists, heart-lung machines, hospitals, and over boundaries. So it's just really important. And that's what we've got to aim. That's the barrier that we need to overcome. And then we can use our data for practically anything. So now I'm going to switch direction a little bit, and just in the last 8 minutes, 10 minutes of the presentation, I'm just going to share with you some results of some work we've just actually got presented at AATS on the weekend. And it's looking at stress hypoglycemia ratio and low oxygen delivery and its association with mortality following cardiac surgery in adults. So by way of introduction, we all know that cardiac surgery has this massive metabolic and perfusion-related stress induced by it. And there are different markers that we can see that reflect that. Now, the stress hypoglycemia ratio has been shown to be elevated in patients undergoing cardiac surgery. And as we know, index oxygen delivery has similarly been linked to outcomes in cardiac surgery. But no one's actually looked at the impact of stress hypoglycemic ratio and cardiac surgery during cardiopulmonary bypass. There's work looking at the period post-surgery in the ICU, but no one's looked at it in the context of the actual bypass period. So our aim was to evaluate that relationship between intraoperative stress hypoglycemic ratio and mortality, stratified by oxygen delivery. Now, it would surprise me if you didn't all know this, but I just want to tell you a little bit about the stress hypoglycemic ratio because it's not a term I was familiar with. It was a new term and a new area for me to think about. But basically what it does is it allows us to look at the glucose changes that are occurring now and relate them to how the patient has been prior to their operation, okay? So what it's doing is using the HbA1c, you can look at or relate what's happening now to the patient's normal physiology in relation to glucose metabolism. And it's actually a significant predictor of clinical outcomes, as I've said. In the ICU setting, a stress hypoglycemic ratio of greater than 1.14 has been associated with a higher critical illness value. And in that setting, you can see that the value they use is the admission glucose divided by the HbA1c with a little manipulation to it to give the ratio. What you see is an outcome that's independent of glucose values, of diabetic status. Now that's really important, and we'll come back to that. And it actually outperforms absolute glucose levels in terms of being predictive in critically ill patients. So just to contextualise what we're talking about, we have two patients. Patient A has a HbA1c of 5.8, so that's normal, and patient B has a HbA1c of 8.2, so that's a bit high. So what that is saying is that they're running at a bit of a higher glucose basal level all the time. So then in the context of a intraoperative hypoglycemic challenge, and I apologise, I'm using millimoles per litre. So in your units, that would be about 240, 260, I think. So, you know, outside of what we'd call our normal ranges, you can see that patient A has a SHR of 1.8 and patient B has a SHR of 1. So for the patient who often has glucose running high, it's not much different to normal. But for the patient who has normal glucose values, that's quite a significant increase. So thinking about our DO2 side of the story, we know the literature, we know the evidence that relates poor management of DO2 to poor outcomes. In our context, we're using a cutoff value of 270. We've published extensively at that value. And as I've said earlier, it doesn't matter. It could be 300, it could be 240. There's always going to be some variation in that. And it's also variation. You know, we talked yesterday about measurement and how well things are reported in the literature. You know, everyone's DO2 is a bit different. So, you know, we've got to take that into account. We're looking at the big picture, not the individual pictures here. Now, these are the beginning of what's called a Lowes plot. And basically, you take this binary outcome that Francesca was telling us about. In this case, it's mortality. And on the bottom axis here, we have the stress hypoglycemic ratio. And the patient cohort is dichotomized into above and below 270. Now, if we look at the Lowes plot, now what the Lowes plot does for a simple person like me, it basically just averages the outcomes that are close to the situation that you're in and allows you to visually see what's going on. So if you have lots of bad outcomes at a certain level or that were related to the variable on the x-axis or the horizontal axis, you'd see something different. But here we see no relationship at all. But then if we look at the situation with reduced oxygen delivery, we see quite a different picture. We see that as the stress hypoglycemic ratio increases, we're seeing that the mortality outcome increases significantly. So just by way of methods for the paper, so we did that to see whether there was a question worth following up on, okay? So, you know, often when you have a big data set, it's really valuable to interrogate it and look for trends. And that's a bit what machine learning is going to help us with in the future, is it's going to pick up things that we don't even know that exist now that are really important in impacting the outcomes that we get. So we've had about 10,000 patients in this cohort. They're all from our Perfusion Registry. You can see the cohort goes back to January 2011. So we were measuring all the parameters we needed to calculate a DO2 for a very long period of time. We've got a range of intraoperative bypass variables, a lot of physiological data. And then we have our demographic and our outcome data. As I said, we've used the nadir DO2 of about 270, and we're looking at the peak stress hypoglycemic ratio during bypass. So the primary outcome for our study was in-hospital mortality, and our second outcome variables were a combined morbidity endpoint, AKI by rifle criteria, and effectively class 1 rifle is effectively the same as KDIGO class 1. The variation that exists in those classifications again becomes a little bit semantic, because when people actually make their measurements and when they report it is very defined in the definitions and very loosely applied in the literature. ICU length of stay, hospital length of stay, stroke, etc. Our statistical analysis, and this is really exciting for some people and as boring as whatever for most of us. But as I said, we had the Lowes plots to help us work out whether there was a question worth asking. We used the Uden's index to get a cut point. We divided our groups based on DO2. We did both univariate and multivariate analyses. I should say just going back to that for a tick, the model was developed based around a priori publications in the stress hypoglycemic ratio literature. So that just helped us guide how we were going to do our analysis in this first look at this sort of area. So just looking at our results, firstly looking at our demography, and it's really funny, you think about how you present data, and I wasn't quite sure how to present this. So I've gone with it like this. It may or may not be useful to you. But we've got to remember, this is not randomized data. This is off the street walk-in data. This is our group with normal oxygen delivery. You can see there are variations between the groups. There's more diabetics in the low SHR group than the high SHR group. But overall, you can see that variation, and then you can see that in the low DO2 group, the patient cohort is a little bit sicker. They're not as healthy. There's more areas that are a bit more variation between the two groups. Now let's look at our primary outcome, which was mortality. In our DO2 greater than 270 group, you can see there was no significant difference between those with low and those with high stress hypoglycemic ratio indexes. Looking at the result in our low DO2 group, we have a mortality rate of 7% versus a mortality rate of 2%. That's a massive difference in mortality in patients that you think are just coming in for routine cardiac surgery. Looking at our secondary outcomes, we can see that, so between those with normal oxygen delivery and those with lowered oxygen delivery, you can see there are massive differences between the two groups. And then you can see within the group, that's where the really interesting difference occurs in that low oxygen delivery group. There's an impact on intubation time, ICU length of stay, overall morbidity, stroke, and AKI. So we're seeing the impact all the way through these patients. Looking at our multivariate model, so was this an independent predictor? And we can see here in our normal oxygen delivery group, Euroscore was predictive, renal impairment was predictive, red cell transfusion was predictive as you'd expect, intraoperative SHR was not predictive. If we look at our low DO2 group, maximum glucose was predictive, mild and moderate renal impairment were predictive, red cell transfusion was predictive, and stress hypoglycemic ratio was independently predictive. It's got an odds ratio there of 2. So you're doubling the risk for your patients, you're doubling the odds of them having a bad outcome by how we manage their glucose during bypass. So what are the conclusions of this? Well, an intraoperative stress hypoglycemic ratio greater than 1.42 is independently associated with in-hospital mortality in patients with low oxygen delivery. This is an outcome that we can impact. So there's, in patients with normal, well-managed DO2, there's no relationship. DO2 we know is modifiable. Stress hypoglycemic ratio index is modifiable. You know, if you think of the situation where, you know, most perfusionists have quality protocols, okay? In my institution, we aim to keep glucose between a certain range. That range is not patient-specific. It's a group range. What this is suggesting we may need to think about is having creating a stress hypoglycemic ratio for each patient prior to surgery, and up there on your dashboard, you say, okay, when Rob goes into surgery, maybe the magic number's 160, maybe it's 180, maybe it's 140, maybe it's 230, but it's Rob's number. And we want to keep Rob below a stress hypoglycemic ratio of 1.4, and we want to keep his DO2 up. And I guess that's the message of what the data's suggesting we might be able to do. So obviously there's a lot more work that needs to be done in this area. This is the preliminary findings. We'll get this published as soon as we can now, but it needs to be reproduced by some other people to see that it's actually valid. So I think that you know, the registry space is incredibly exciting and it's incredibly valuable. I like the idea of being able to share as widely as we possibly can. I think it's really important to be able to, at your hospital, drill into your data and have a dashboard or a window to your data that's incredibly flexible. You know, if you think about our old reporting structures, you know, we were locked into a time period. With the way we're set up now, if you want to look at the last month, you can look at the last month. If you want to look at, we're not got the ability at the moment to look at X number of cases, and I need to build that in. But if we want to look at a year, if we want to look at 5 years, if we want to look at males, we want to look at females, we want to look at different body sites, if we want to look at different racial groups, you need to be able to do that to see what you're doing. We just don't know what impact we're having. Anyway, that's my soapbox. So thank you all very much.
Thanks, Rob. Great talk as always. You know, we have at length discussed registries and how we do data and what we need to do. So I'm sure we'll continue that for a while. There are a number of interesting comments on the chat, but we'll stem them first and then we'll come back to that, please. So,
Rob, thank you. That was a fantastic talk, and I completely agree with you about the power of integrating across countries. But I guess the aspects I wanted you to comment about is the barriers in regards to data sovereignty, you know, and then also the way in which you enter the data into a centralized platform needs to be same. Like I think if you enter the data in different ways in different countries, you know, I think is, you know, should the first step be to make a centralized platform where everybody enters the data in a similar way? And I guess then you got to work with organizations about their risk appetite and the data sovereignty. I mean, what are your thoughts on this? Because I think if you can do this properly, there's a lot of opportunities for collaboration, machine learning. Yeah, just your comments.
So it's, I mean, one of the brilliant things about our specialty is that, you know, we have good relationships with our manufacturers, and we have all of that standardized heart-lung machine data. So I think that forms the core for the standardized data set. We all know there's going to be variation in terms of how clinical data is reported. And, you know, we have the STS database and the ANZ database in our region, and the definitions on some variables are different. It doesn't matter. What matters, I mean, when we report using that data, we have to take that into account. But the core elements, as long as we can be confident that from the perspective of, say, our electronic data, we should be able to control that fairly well. But I think I've jumped ahead a little bit on your question. In terms of, yes, we have to have regional databases, you know, cloud-based registries. And then if they're sharing de-identified data to a global database, it's very much embryonic. You know, there's a lot of discussion happening around what it might look like and how we might go forward. We just need to get through some of the barriers. Yeah, and the barriers are not as big as they used to be. You know, the technologies come ahead in leaps and bounds, and is a lot more accessible, both from a ability to use it perspective, but also from a cost perspective. So you know, I think we're in a happy space. We just got to keep moving forward.
Hi, Greg from Boston. Thank you very much for that presentation. I have a comment and a question. My comment is, midway through your presentation, you mentioned data security, and I'd like to recommend two-factor authentication.
Thank you.
No, my serious question is, you have a massive amount of experience in the registry space. Have you ever thought about collecting data on oxygenation strategy?
Look, that's a really good question. I think when we do this next, we're talking with industry at the moment about getting data out of our heart-lung machines better. And as part of that, we then have to work out how we can get metrics of what we're doing better. Because, you know, if you think back to the Registry randomized trial, and in that there was some discussion around what people did. Well, it was not of high quality because it wasn't recorded well. If we have the right, you know, keys on the Essence heart-lung machine or the Spectrum heart-lung machine, then we can say, you know, we've transfused for DO2 reasons, you know, or, you know, this pump flow increase. Yeah, I'm not sure what those metrics look like, but you're absolutely right, Greg. We need to be, and not just around DO2, you know, the whole hemofiltration issue, you know, why were you hemofiltering? You know, and we don't have that as a routine data collection.
Yeah, so I think it's very exciting that, you know, part of at the end of your presentation was starting to look at things together, you know, the stress hormone response and DO2. And I think that's where we're really going to find usable data for our programs, is putting 4 or 5 things together. Thank you.
I mean, we could carry on for a long, long time. Unfortunately, we've run out of time now. There are some questions online that we will try and get around to answering as well. But unfortunately, we've got to move on. So thank you very much, Rob. It's been wonderful.